Thank you, Aideen, and thank you to the HRB for the opportunity to present today. And I really enjoyed, I have to say, the morning session. And there's some common themes, I think, that we elicit over the course of our session today as well. So I'm also a medical oncologist, so really my talk today will focus on cancer therapeutics. And we know that precision cancer medicine or precision oncology has much wider implications than just therapeutics. But for the short talk today, and I promise to keep to time, Aideen, I'll stick to just cancer therapeutics, really. So back to basics. I mean, cancer is a very common disease, right? And we're all familiar with the concept of cancer and treatment with chemotherapy. But sometimes it's good to pause and think about what we're actually doing as medical oncologists and the rationale behind our therapeutic decision-making and the drugs that we have developed over the last 50 years or so to treat cancer. So these are the kind of images we look at all the time in our clinical meetings, our MDT structures in oncology. Cancer cells essentially are fast-growing cells, right? That's the fundamental change that makes them different to a normal cell. So you may be having horrible flashbacks to college here, but on the left side, you can, this is a benign tumour of the muscle wall of the uterus. So it's fibroid. And on the right-hand side, that's a cancerous leiomyosarcoma, so a malignant tumour of the muscle wall of the uterus. Now, they look different, don't they? And the reason they look different is simply because the cells in the picture on your right-hand side are growing faster. The nuclei are large and they're packed with DNA. So essentially, the fundamental thing that makes a cancer cell different to a normal cell or its cell of origin is its ability to replicate fast. And that was one of the first observations that were ever made about cancer cells in terms of cancer biology, long before we had molecular diagnostics and next-generation sequencing and all the tools we have at our disposal today. These H&E slides were what we've always relied on in the pathology department and still do. And so the first treatments we developed for treatment of cancer, systemic treatment of cancer, were very simply drugs developed to stop cancer cells from replicating, or really to stop any cell from replicating at a fast rate. And that's what all of our cytotoxic chemotherapies essentially do, albeit in different ways. So the old-fashioned concept of chemotherapy, the drugs that we rely on today, the 5-FUs and platinums and all the drugs that we're familiar with, and that treat and have huge benefit for management of common cancers, they all converge in the same mechanism of stopping cancer cells from growing, dividing, and making more cells. And the principle around this is that cancer cells divide and grow faster than normal cells. And so chemotherapy, ideally, has more of an effect on the cancer cells than on a patient's normal cells. So, well, that's a risky strategy, isn't it? Because at the end of the day, there's still many fast-growing cells in our bodies. And when you think about it, all of the side effects of chemotherapy that our patients suffer from when they receive chemotherapy are really all due to the effect of cytotoxic chemotherapy on the fast-growing cells within their body. So what grows fast in our body? Well, bone marrow cells grow fast. Our hair follicles, our skin, the mucosal lining of the mouth, of the gastrointestinal tract. And as we deplete the ability of those cells to replicate with chemotherapy, we cause side effects. And those side effects are toxic to our patients and put them at risk. And that's bone marrow toxicity, neutropenia, anemias, low platelet counts, it's hair loss, it's fatigue, and it's diarrhea, it's sores in the mouth and mucositis. So all those common side effects are a result of us being unable with conventional cytotoxic chemotherapy to adequately, precisely target the cancer cells. We have so many other effects on the patient's normal cells. And that's really the problem with chemotherapy. And don't get me wrong, I'm an oncologist, we rely heavily on chemotherapy, but this is what limits our ability to give sufficient dose of drug to really target the cancer cells, because we're also causing toxicity to the patient's cells. So we've relied on chemotherapy for a long time, but how can we do better? And of course, we have done better in terms of developing better cancer therapeutics over the last decade. And that's really come in the form of two main achievements, and that's been in the field of immuno-oncology, so development of immunotherapy drugs, and in the field of targeted therapy, molecular targeted therapy, where we identify vulnerabilities in the cancer cells, which are specific either to a patient's cancer specifically or to a subtype of cancer or primary site. And we can develop rational therapeutic strategies to avoid to target the vulnerability and then target the patient's cancer cells and relatively well spare the patient the toxicities of cytotoxic chemotherapy. And so in treatment of cancer, these type of treatments have entered routine clinical practice. And that's, I suppose, in the field of some common cancers, in particular lung cancer as a good example. And how we made that leap forward? Well, it's a move towards precision oncology. So precision oncology really has entered clinical practice in the realm of cancer treatments. What's happened over the last 20 years is we've understand better the molecular underpinnings of what makes that cancer cell divide more quickly than the patient's regular cells. Rather than just targeting the fact that cancer cells replicate quickly, we've identified the mechanisms by which that occurs. And by targeting upstream, by identifying those mechanisms and by blocking them with rational therapeutic strategies, we can have more of an effect against the cancer cells and less effect against our patients. Not that these drugs are without side effects, but usually significantly less than cytotoxic chemotherapy. So some good examples of that would be, for example, identifying that cancer cells and tumours as they grow can induce angiogenesis, or they can make blood vessels grow in a disordered fashion that can feed the tumour. And by blocking VEGF signalling, we can inhibit the development of such blood vessels. Other examples would be CTLA-4 blockade or PD-1 inhibitors. So this is where cancer cells have the ability through expression of a protein on the surface of their cells to evade the normal immune surveillance system. And essentially by blocking that molecular break on the immune system with antibody therapy, we can allow the patient's own immune system to recognize those cancer cells as foreign and to target the cancer. So all good strategies, of course, none necessarily perfect, but the idea we're moving beyond just targeting fast-growing cells to targeting the molecular mechanisms that result in cancer initiation, progression, and metastasis. So we know, as an example in terms of targeting molecular alterations, that genetic alterations are a key driver of cancer development, and they drive most of those pathways I showed you in the earlier slide. So for those of you who aren't familiar with looking at CT scans, these are two good examples of some of the first molecular targeted therapies that entered routine clinical practice in oncology. And this is now well over 15 years ago, almost 20 years ago, in terms of the first example. So we know that in terms of lung cancer, which is a major cause of cancer mortality and morbidity, that about maybe 20% target a mutation in EGFR, epidermal growth factor receptor. And that causes sustained proliferative signaling from the EGFR receptor and helps the cancer cells grow and multiply quicker. So EGFR mutant cancers, we can actually target with an oral therapy the EGFR mutation, and we can block EGFR signaling. And this, when this publication occurred in the New England Journal of Medicine, now almost 20 years ago, was astounding, because we've never seen responses like this before. So those of you who aren't familiar with looking at CAT scans, you can see here in A, this patient has got almost complete replacement of their lung with advanced lung cancer. And after just 2 months of treatment, you can see significant clearing in that tumour, and that's with a tablet taken daily with minimal side effects. So an example in practice, in clinical practice, of how targeting the causative mutation in a patient's cancer can have astounding clinical results. The other major success, and again this is now almost 15 years ago, was the identification of BRAF V600E mutations in patients with advanced melanoma. Melanoma, as many of you know, is very, very resistant to cytotoxic chemotherapy, to the point where it is almost essentially not useful at all. And this is a PET scan. So the areas that are dark here are predominantly areas of cancer activity. Of course, the brain lights up and the heart lights up, but all other areas you can see lighting up on this PET scan are areas of cancer activity. And after the patient who had a melanoma metastatic containing a BRAF V600E mutation was given, again, a single oral therapy daily of a BRAF inhibitor, you can see almost complete resolution by day 15, 2 weeks of treatment, in terms of activity of that cancer. These were New England Journal of Medicine publications because they were astounding in the field at the time where we'd been so reliant on cytotoxic chemotherapy. So these are drugs we now use all the time. And of course, they're not miracle drugs. We've realized that. Resistance emerges usually 4 to 6 months after initiation of therapy. we now need to develop strategies around identifying resistance mutations in circulating tumour DNA and next generation inhibitors, which can then provide perhaps additional tumour response and disease control. But it's proof in principle that targeting the molecular alteration that's driving a tumour can have significant clinical benefit for a patient. And I think one of the earlier speakers made the very important point that the whole point of precision medicine is to benefit the patient, that the right drug gets to the patient at the right time. So to that end, I suppose I've shown you a little bit of how we've made advances in standard clinical care in terms of advancing precision oncology. How in the research arena can we drive that forward? What's the future look like in terms of precision oncology strategies for cancer? And this is an example of a study, a small study, which is an industry academic partnership between Trinity St. James's Cancer Institute, Genuity Science and British Columbia Cancer Agency, and part funded by Science Foundation Ireland as part of the Precision Oncology Ireland Consortium. And essentially what we've developed is a prospective study of whole genome transcriptome sequencing of extreme phenotypes in gastrointestinal cancers. That's my area of subspecialty. And why extreme phenotypes? Well, this is a concept in terms of studying molecular changes in cancer that we hope and previously has proven to be more fruitful in terms of identifying novel alterations that are not previously described, not previously well characterized. If we're only going to look at a smallish number of patients over a short period of time in such a pilot study, it makes sense to choose the patients who present clinically in an unusual manner. And that's the idea of studying extreme phenotypes. Extreme phenotype just means there's something different about that patient. So what could that be? Could it be they present at an extremely young age? It could be. Could it be that they are entirely unresponsive to a treatment that most patients would respond to? Or it could be that that patient responds extraordinarily well to a treatment you wouldn't have expected them to do so. It could be it's a patient that actually has a very poor prognosis but turns out to be cured of their cancer 5 years down the line. Or it could be the case of a patient who has a successful surgery but unfortunately the cancer reoccurs within 2, 3, 4 months post-surgery. So what we're looking to do is target the patients who are at this end of these curves and say, okay, what's different about those patients? And by studying that small number of patients, we might identify and develop information from that study and sequencing results that would inform perhaps strategies for validation in the larger patient population. And really we're looking to identify potentially causative genetic factors, prognostic factors, and potentially actionable therapeutic targets in a minority of patients, with the ultimate goal of improving clinical decision-making for cancer patients. What does it look like in the patient end? Well, essentially, they provide samples of blood and tumour tissue. It has to be a research biopsy performed specifically to make sure that we're sequencing the tumour taken at that exact point in time. And that's because we know that there can be evolution of genetic changes over time over the course of a patient's treatment. There is a whole genome sequencing, transcriptome sequencing performed in collaboration with our partners. And we send the information to British Columbia Cancer Centre, where they have a bespoke bioinformatics pipeline developed for their personalised oncogenomics platform to identify a potential driver gene or causative etiology. And then most importantly, there's a MDT, as was discussed by Norman earlier, where we then will meet with our experts in Vancouver, discuss the individual patient's clinical experience so far, the treatment so far, and then consider what the best treatment might be. And that might be repurposing a previous treatment, or it might be something we hadn't previously considered. It could be an experimental treatment we have to try to access for that patient. But the ultimate goal of it is that we can then bring those results back to discuss with the patient in clinic what perhaps the optimal treatment strategy might be. It looks really simple when you present it like that, but actually there's huge challenges to implementing this type of program in the clinic, because we're talking about patients who are alive and waiting for their results. So in terms of timeliness of biopsies, of processing, of sequencing, of the very, very complex bioinformatics structure required to bring the information in whole genome sequencing down to a patient, individual patient level, and then to have the right people in the room to discuss the correct strategy for that patient needs to be done within 12 weeks for my patients to potentially benefit from that. So that's really the bar we've set, and this pilot study is to look and see, can we do that in a public oncology clinic in Ireland? So we're looking to sequence about 30 patients. We're opening just this year in St. James's Hospital, and really to develop that infrastructure and that capacity building. I see Aidan standing up, so I'm going to finish in about 1 minute, Aidan. I just want to mention one thing. I think we could maybe discuss it perhaps when we have the questions at the end, Because looking forward, this is on a small level research program that we're developing to develop our capacity, but on a larger scale, how can we look to ensure that patients living with cancer in Ireland may have access to the right drug at the right time? And we can look internationally to experience, in particular of our European colleagues, in terms of how it's been done elsewhere. A lot of this really circles around drug repurposing studies in oncology. We've heard about the importance of novel clinical trial design. And we all agree we're moving away in personalised therapy from the standard phase 1, phase 2, phase 3 approach to more flexible, perhaps platform design, joint umbrella basket studies. And there's very good international examples, and particularly from the Netherlands, from Denmark, from Norway, from Canada, of large-scale national studies that have utilised this type of platform study approach to make sure that patients have access to comprehensive genetic sequencing and that they have access also to a drug that might help them. And most importantly, that we are capturing that information in a prospective study and ensuring that it can be used to assess the utility of that drug in that individual patient or group of individual patients at that time. So no time to go through that in a lot of detail, but I'm going to say that, as Norma pointed out, cancer molecular diagnostics infrastructure, so access to the testing is really important. A molecular tumour board is really important. As I think our earlier speaker before the break mentioned, there are some key learnings from the international experience, and I thank Professor Chaskin from Oslo for his slides. He's been enormously helpful in giving some insights into their experience. But it's really more than just developing a trial. It's about developing an infrastructure, a system for public-private partnership, looking at drug reimbursement. It gets more complex the more you look into it, but there are very good international models of how, in a relatively small country, we could perhaps have a large impact and partner with our European neighbours in that manner. So the key enablers, and I'll finish on this one. We need, Richard is here, and so we've heard me say this a million times, a national strategy for development of key infrastructure for cancer molecular diagnostics, and hopefully, and I'm very hopeful that the new strategy for genetics and genomics is going to further that in a major way. We need support for professional development of the people who do the work, so clinical scientists, bioinformaticians, molecular pathologists, clinical geneticists. These are all people that are really, really important in developing this type of a strategy. We need, and I echo again earlier speakers, to invest in academic and industry partnership, because really this is where innovation will happen. Public-private partnership, again, international models tell us that's really, really important. And partnership with our patients. There was a lovely phrase used in the video we saw just before this session, a co-creation of healthcare with our patients. That's a lovely phrase, and I think that's a wonderful mantra for us to remember as we move forward.